Hello again. My name is Sara Raafat. I'll be presenting an interesting case for the MSK group. Special thanks to my colleagues Abdullah Mursi and Muhannad Ghunaim for putting the case together, and special thanks to Dr. Amina Osama and Nada Aidel for their supervision and inspiring guidance. Now, our case is of a 30-year-old female with pseudo-winging of the right scapula. Now, winging of the scapula means sticking out of the scapula posteriorly, and it is usually attributed to dysfunctional muscles that are responsible for stabilizing the scapula during motion. So mainly the long thoracic nerve and sometimes the spinal accessory nerve. So because it is related to motion, it's likely to be more obvious during stretching your arm or pushing a wall. But pseudo-winging means that the sticking out of the scapula, the deformity is present at rest and it is not affected by motion, which makes you think that this is rather anatomical rather than functional problem. And this is what the orthopedic surgeon thought as well and ordered an X-ray. Now the X-ray shows the thing that we expected to see, if you can spot it. It's over there. There is a exophytic bony lesion from the medial aspect of the scapula, and on the lateral view of the X-ray, you can find it is more related to the ventral rather than the dorsal aspect of the scapula. Now, we're thinking of it, but hold your thoughts. We have a CT. Now, here is the CT, and you can clearly see the exophytic well-defined bony outgrowth from the ventral aspect of the, here it is, from the ventral aspect of the medial border of the scapula. And you can appreciate that there is no bony destruction or cortical destruction, which is important. Now, with the coronal image, you can see that the osseous protuberance is in direct continuity with the scapular cortex and medulla, making us all confirm the suspicious that we had at first, which is osteochondroma. Now, because we like to use all of our tools and for other reasons, the patient had also an MRI. And in the MRI, you can see the exophytic bony lesion from the ventral aspect of the medial border of the scapula. And you can also appreciate the cartilaginous cap. And this is actually important for you to measure the cartilaginous cap thickness to calm down the patient's concern of whether or not this is something bad or ominous. Here is also the axial proton density and the axial T2. And in the axial T2, you can also appreciate the presence of fluid-filled bursa related to the osteochondroma. Now, when it comes to treatment, osteochondroma, if the patient is not complaining and it is a place where there is no problem, you usually calm the patient that it's fine, it's something you can live with, and send them home. But in our condition, and because of the winging of the scapula, led to more limitation in the movement, and because of the bursa that could be attributed to the pain that the patient was experiencing, the patient had it excised, and it was our good fortune that the photos were sent to us. Here you can see it, the beautiful mushroom-shaped textbook appearance of the osteochondroma and the covering hyaline cartilage. This is the pathology report for our patient, osteochondroma. Now, osteochondroma is by far the most common bone tumor ever. 15 to 20% of all bone tumors and up to 50% of benign bone tumors are attributed osteochondromas. It's interesting to know that osteochondromas can be congenital or can be secondary to surgical or trauma, especially Salter-Harris fractures, as well as irradiation, because they think that it is attributed to transplantation of the epiphyseal plate tissue to the cortex. With time, it grows into osteochondroma. Now, the diagnosis is around the fact that the cortical continuity and the medullary cavity continuity of the bony outgrowth from the parent bone. That's an ugly looking osteochondroma, which is the major concern of the patient. Can this turn into something more than just a benign lesion? We have our criteria to say if it is benign or it's going to have a malignant transformation. The features include growth after skeletal maturity, newly developed lucency, scintigraphic activity, which is a change in it, this cortical destruction, which can be clearly visualized here, pain, soft tissue mass, and thickened cartilaginous cap, which is why we order MRI to be able to efficiently measure the cartilaginous cap. This is a case just to show you how thick the cartilaginous cap can be. It cannot get any thicker than that. This is a chondrosarcoma. Now, the learning points is that the patient history actually is relevant. The winging of the scapula points toward a direction rather of anatomical rather than functional, and that MRI helps to assess for complications, especially the cartilaginous thickness, the irregularity, the soft tissue thickening, and the invasion of the surrounding tissue. Thank you.
شكرا يحيى وسارة، ممتازين ما شاء الله. Now we start the discussion.